So for the first thing we're going to do, like I said, on the go, you see there's nothing on the screen. I'll give you a case. We will work it through, right? So the case is a 38, 35-year-old female, right? Represent to the outpatient clinic, right? Outpatient clinic. What is the complaint? Complaint is pain in both knee joints, right? Also has pain in a small joint of both hands and feet. These are what are called buzzwords. The case, they're always going to give you something from the beginning. You should be thinking about something in your head right now. Sometimes the joints are very tender and swollen. And so you make the patient always tired, fatigue. That's what she complains about. When she does small things, she gets tired. She may also have some mild fever and then weight loss. She reports of alopecia, so hair loss. Does this give you a clue? What do you think this is going on with the patient? Like, does this give you an idea? So somebody said rheumatoid arthritis, so we'll put it here. Rheumatoid arthritis, right? She said this has been going on, is alternating with the exacerbation and remission. So it goes back and forth. Does that give you a clue? I think it's cancer. So let's put it here. So that's what somebody thinks this is cancer. That's our differential diagnosis. The further examination shows that she reported about chest pain, sharp chest pain, okay, with inspiration. And this is relieved by leaning forward. This pain is relieved by leaning forward. So does that give you a clue? You look at the client map, you saw oral painless, oral ulcers. That's what he saw. Is he coming back? Somebody think this is pericarditis. Or painless oral ulceration. And the UAP, the LPN said, well, there is no joint deformity that she can see, but the patient has pain. Flat, raised rash on the malar surface of the face. That's what the next further examination shows. It's very pale. Does this give you a clue? There's no abdominal fluid. You don't see anything. Still, no clue, right? Based on what I've given you, if I said, okay, now let's do a lab work. What kind of lab would you want to order? Let's get some CBC. Some CBC. We get some BMP. We get some UA. Somebody say, let's get an EKG. Sure. EKG is a study, okay? It's not a lab work, but we'll order EKG. CBC, what you saw was platelets RBC, WBC, all low. This is what we call Pancytopenia. BMP, I think this is easy. There's no idea. You get a BMP, creatinine, and BUN is elevated. Somebody say SLE, systemic lupus. So the creatinine and the BUN elevated, blood cell, RBC, platelet, white cell, all low. We have pancytopenia, right? You get a urine analysis, you have class 3 proteinuria. And you saw RBC cast over there and some blood in it, hematuria. Does this give you enough information? Let's look at it. Age, right? I give you the age. I give you 35-year-old. Both joints, large joint, and a small joint. Why would this not be rheumatoid? Just one word should tell you this is not a rheumatoid arthritis. Why would this not be a rheumatoid arthritis? Why do you guys think that? Why would this not be a rheumatoid with that statement? Both pain in both knee joints and small joints of the hands and feet. Why is not rheumatoid? It's a content musculoskeletal. You can check out Dr. Claus. I have a great video on musculoskeletal. You can watch it. Basically, you have to master everything. There's some on the NGN code or in the membership, and you can watch it. But the rheumatoid arthritis, these are key that will tell you it's not rheumatoid. What are you supposed to see in terms of the pain for rheumatoid, guys? The joint is going to be small joint and it's bilateral. It does not involve big joint. Knee joint is a large joint. This is a small joint, yes, but rheumatoid should not have a knee joint problem. Therefore, that's why this is not, it cannot be this. This cannot be cancer because you shouldn't have alternating symptoms, right? Alternating. This keep on going back and forth for over 3 months. It cannot be cancer. Morning stiffness, somebody said morning stiffness. Yeah, rheumatoid, but still, that is good. I mean, morning stiffness is also good for rheumatoid. Cancer is not going to show you that. Pericarditis, you only had one information. Pericarditis usually is some acute inflammation, or it can be anything. So you cannot just use this as leaning, sharp chest pain, leaning forward, relieve chest pain with inspiration, relieve by leaning forward to be only pericarditis. You can't take one information. I've given you all of this. This is why NCLEX case study, you can't just focus on one word and say, oh, this is it. You got to connect the dot. I won't, if this is pericarditis, I'll have told you from the beginning. This is extra information to help you. That's the way you do case study. So all this, I give you a rash, flat raised rash on the malar surface of the nose. I give you no joint deformity, right? I told you there is this, oral ulcer. This is what we call after ulcers, right? This patient does not have pericarditis, does not have cancer, does not have rheumatoid arthritis. You have to come up with more differential diagnosis, figure out. Somebody say SLE, maybe the person may be right. We will see. But this can give you a clue. We have pancytopenia, right? We have elevated creatinine and BUN is elevated. We have proteinuria, we have cast, you have hematuria. This is the lab work you expect. We need more lab work. What do you think we should order? What do you think? If we think this is SLE, if somebody think this is systemic lupus, what lab work are you going to order then? Tell me in lab work you should order to prove yourself that you're having systemic lupus. We already had a bunch of them. We ordered this one. You need additional lab work to confirm it. So which one? What lab work? I will tell you the one of them, NA, right? Anti-nuclear antibodies. So you need anti-nuclear antibodies. What other lab work will you order? Or the lab work will you order? So this is not cancer. It can be cancer. Because of alopecia, no. This is more than that. Cancer does not present like that. Well, other lab work. Anti-nuclear antibodies is ordered. What else you want to get? If you think this is systemic lupus, what other lab work, guys? I can tell you, you should get VDRE, like syphilis is also going to be positive. They have syphilis antibodies related to that. What else? Somebody say ESR. Maybe, sure, we order ESR. It may slightly be elevated, but it's not going to be diagnostic for lupus. It will show any inflammatory process. If you think this is lupus, you should also get, if you are in nursing school, this is very important. If they give you case study too, this is important. You have to know anti-SM antibodies, smooth muscle antibodies. And the last one, this one is the big one. Anti-double-stranded, okay, DNA, you should not forget this, antibodies. If they give you a case study and they don't give you this, if you think this is SLE, then I'm just giving you content, right? This is what lab work you should expect. If they give you a case study, they will give you this. If we think this is rheumatoid, we should order what? If we think this is rheumatoid, what lab work are you going to order? What lab work? You're going to order rheumatoid factor, RF, right? Rheumatoid factor. It will be elevated, but we don't think this is a rheumatoid disease. So that's what you're going to order. And this is a case study for you. Simple, straightforward. I've given you a 35 both joints, knee and a small hand joint. This is tender, fever, weight loss, alopecia. These keep on coming back and on and off for 3 months, alternating. Chest pain relieved by leaning forward, some ulcers in the mouth, no joint abnormality. There's a rash on the face, on the molar surface, and it's flat and raised, right? These rash get worse. Additional information, it get worse in sunlight, so photosensitivity. This is just to give you additional information to help you make a diagnosis, right? The skin is pale. You order some lab, you have Pancytopenia, your creatinine is up, your BUN up, you have Proteinuria, you have RBC CAS, you have Hematuria, and your lab work anti-nuclear antibody is positive, VDRL positive, ESR elevated, anti-SM smooth muscle is elevated, anti-DNA also elevated. These are content you got to master. Okay, so did anybody make a diagnosis? Yes, this is systemic lupus. Classic systemic lupus is an autoimmune disease, affect your body make antibodies that affect your skin, your lung, okay, your kidney, and your joint. Almost every organ in your body can get affected by that. And if they give you a case study, this is what they will include. Key features: the rash is photosensitive, right? So it's worse on sunlight. And it's very erythematous. We call it Malar rash. Some people call it butterfly rash. Why? It crosses the bridge of the nose. That's why it's called like that. So it crosses the bridge of the nose. So if this is the individual nose, okay, with their face, you see a rash. It starts from here, it crosses this, and it comes here like that. So that is the molar rash in their face, basically. This is Malar rash. Systemic Lupus Erythematosus. Now, tell me what you want to do then. What is your plan? What is your management? This patient is an outpatient, so what kind of management or intervention you're going to implement? Now tell me, I've given you the diagnosis. What are you going to do with this patient? You're going to get some medication. They will going to get teaching how to take care of themselves to prevent relapse, right? So what kind of medication would you think this patient is going to need? Tell me. What medication will you provide this patient? What medication will you give this patient? Okay, steroids. They get steroids. What else? What other medication will you give to this patient? Immunomodulator. What else would you give the patient? NSAIDs. They get NSAID in addition. So these are medication that they will get. NSAIDs, you got to teach them, right? Take it with food. Okay? Don't take it with the empty stomach. Take it with food. I mean, corn with black tarry stool. So avoid other NSAIDs together. That's the teaching you provide them. For steroids, you got to teach them things not to do, right? Steroids, you know the side effects, right? Cushingoid symptoms, right? They're going to gain weight gain. Therefore, exercise, right? Osteoporosis. What are you going to tell them about osteoporosis? Right, one of them. And think about this patient. What is the biggest problem with this patient? I told you sun exposure. Therefore, if this patient taking steroid, there is an accelerated rate of osteoporosis. Why? Why is there going to be accelerated rate of osteoporosis in this patient? Guys, so what do you teach? Are you going to teach this patient to do? Of course, they're going to avoid the sun, 10 a.m. to 4 p.m. Remember, we make vitamin D on sun exposure. And therefore, if these people are not going to the sun, they have less amount of vitamin D. Therefore, and they're taking steroid too. So less amount of vitamin D and taking steroid, they're going to have osteoporosis. Therefore, they should get supplement of vitamin D, and calcium. Otherwise, they will develop osteoporosis. So these are the things you teach them. Other side effect of steroids, you know, right? Buffalo hump, abdominal stress, all those things you teach them, and avoid infection and other things. What other medication? Immunomodulators, hydroxychloroquine. If they give you a test, they will give you this medication. Hydroxychloroquine. Who knows number one side effect of this medication? There's one thing you should not forget: retinal damage. Therefore, they should see ophthalmology every 6 to 12 months to prevent that. Okay? They may probably also be on methotrexate. Methotrexate mostly it causes methotrexate mostly causes liver damage and is a teratogenic. So they shouldn't be taking anything that are related to that will affect the liver. Okay, they can also have like cyclophosphamide. What do you guys think? Major side effect of cyclophosphamide. Hemorrhagic cystitis. It's hemorrhagic cystitis. This is a major side effect, hemorrhagic cystitis of cyclophosphamide. So these are medications you give to them, and then they have to use it. All these medications are bad medication. They are immunomodulators, steroids. All these things is important. It's going to make the individual immunocompromised. Therefore, neutropenic precaution. Avoid live vaccine as much as possible. What else should they have to do? Avoid sick contact, right? Avoid sick contact as much as possible. That's what you're going to tell them. You're also going to tell them, like, don't drink from water fountain, right? Avoid crowd, right? Get your annual vaccination as much as possible. So you avoid fresh vegetables, right? Hot dogs, right? Don't eat at the corner store, right? Don't eat at the corner store or the hot dogs, right? What else? They can also give you about the vaccination. This patient need to avoid live vaccines. So what vaccine should they avoid? MMR, right? What else? Polio. Nasal flu vaccine. Rotavirus. Varicella. Varicella is a live vaccine. HPV, they should also avoid. They can get this vaccine, Tdap, right? Tetanus, diphtheria, and then pertussis. They can get this vaccination, right? So these are the things they should avoid. This one is okay. They can get IM flu vaccine. They can get IM polio, right? They can get meningococcal. They can get pneumococcus and H influenza. These are safe vaccines for them. They cannot have live vaccine like this one. So this one is negative. This one is positive. This patient can have it as much as possible because it's acceptable, right? The major risks for these people, what is going to kill them? Killer, kidney function. So when you see evidence of glomerular nephritis, this is number one. It's a priority. Kidney failure is number one. When you see it, you know this is a big, 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 big problem. They're not doing well. But they can have pericarditis, like we saw. They can have pleural effusion. Okay, they can have DVT. It's common, but kidney dysfunction is number one that is going to kill them. So as soon as you see it, you should be doing something about it. That is your priority with this patient. Okay, so this is everything you need to know about CLE, systemic lupus, the diagnosis. We talk about a 38-year-old lady with the both knee, both joint, mild pain, weight loss, alopecia, photosensitive skin on the molar face, that across the bridge of the nose is raised, maculopapular erythematous rash. There's aphthous ulcers. A lab work shows pancytopenia, creatinine is elevated, BUN is elevated, as ANA antibodies, anti-SM antibodies, anti-double-stranded DNA antibodies. We talk about the treatment. You give them immunomodulators, steroids, cyclophosphamide, hydroxychloroquine, the side effect of these medications, methotrexate, and then things you should be teaching them not to do and what to do, like in terms of avoiding live vaccine. Apart from that, there's other things you can do too. You can teach them some few teaching, right? Avoid stress, right? This is stress is number one that will trigger them. You should avoid stress as much as possible. And then use some sunscreen. And then for the rash in their face, tell them to use a specialized makeup, to cover up the rash. You can tell them they shouldn't forget vitamin D supplement, right? These are the things you tell them, and then neutropenic precaution as much as possible. We know that this is no rheumatoid, so if I'm giving you a case, I will give you like small joint. I put small joints here. I put butterfly. What is the? I'll put fatigue. Right. This is the last thing. I'll put Malar rash. I'll put morning stiffness, and I'll put oral ulcer. I'll put joint pain. And then I put the rheumatoid here, rheumatoid arthritis and systemic lupus. This is 1, 2, 3, 4, 5, 6. And if you have to compare small joints, basically hands and feet, right? So which one belongs to which one? I can tell you there's no molar rash in the rheumatoid, so it will be systemic lupus. Both of them are going to have morning stiffness because it's a joint problem. In rheumatoid, it's systemic lupus. They're both going to have joint pain. And both of them are going to get tired. In small joints, both of them are going to have. So this is the way it's going to look like. They look the same, they don't sound the same. specific things that will go against it. Both of them are treated the same way. They are all autoimmune diseases. So you will need immunomodulator. All the medication we use, it can be used to treat them. This is Adapting Place. Thank you for joining us. I hope you have a good day and keep charging as always.